Now like to introduce Dr. Hamvik, who will begin today's presentations about gender affirmative medical interventions. And so Dr. Hamvik, we're so excited to have you. Dr. Hamvik completed his residency and chief residency at Brigham and Women's Hospital in Boston, Massachusetts. He's currently the program director for the Endocrinology Fellowship at BWH and co-directs the BWH program in transgender health. Welcome, and we are so excited for your presentation today. Thank you, sir.
Well, thank you again for inviting me and for having me. I am very excited to be able to talk to you. I am talking on the topic of gender affirming medical interventions, which is a big topic, a broad topic. So I'll try to do it justice in the amount of time I have available. But hopefully there'll be, it'll give a nice overview so you have a sense of what sorts of interventions we can offer that are non-surgical. I think it's helpful to think of certain kind of big buckets in gender affirming care. And I sort of listed them here on top of an arrow, sort of suggesting that you start on the left and you go to the right, which isn't always true. And but it's a helpful framework to use as you're starting off. So, you know, we think about confirming the gender identity, maybe the mental health piece, as was alluded to earlier today. Then we think about hormone therapy and we think about surgeries. Before we delve into the hormones, I did want to say that there are other aspects also to healthcare that we can provide to our transgender and gender non-conforming patients. So first of all, there are parts that aren't maybe necessarily healthcare, but that can be really as important for the patients as the healthcare. I listed some of them here. So, you know, peer support groups, for example, the use of prosthesis or binders, the legal help, for example, with changing the gender marker on driver's license and passports or birth certificates. Voice therapy can be very important to help people often feminize their voice. And in addition, you know, we're talking today mostly about the aspects of medical care that are specific to transgender individuals. But like anyone else, transgender individuals need primary care. They need routine health maintenance. They need their cancer screenings and their vaccinations and all of those things. And I say that, and you'd think, well, that's obvious. But I will also say that I have had many patients, transgender patients, who have been denied routine health maintenance because they were the healthcare provider felt like this was too complicated, they couldn't handle it, and that's obviously not what we want. So I think it's important to bear that in mind. But I'm going to delve into kind of some of the more transgender specific aspects of care. And the first sort of bullet point here is, you know, confirming gender identity and assessing for psychiatric comorbidities. So we have criteria in the US, the DSM-5 criteria for this diagnosis of gender dysphoria. I will say the language here maybe is evolving, but I think it's helpful, you know, for you to just kind of look at these criteria. I highlighted the important parts in yellow, and you can see that it's basically confirming that someone has had more than 6 months of gender incongruence. So an incongruence between the patient's gender and the sex that they were assigned at birth. Turns out, if you look at this, it's sort of like a checklist, if you want, and this is in a mental health manual. The DSM-5 is a list of mental health diagnosis with mental health meant for mental health professionals, which raises the question of, well, you know, who should patients who are transgender, who should they see to confirm this diagnosis? And I'm using the word diagnosis because that's how it is used, but you could argue whether that's the right word. But you know, in children and adolescents, I think there's fairly uniform agreement that this diagnosis should be made by a mental health provider. So all children and adolescents who are thinking about medical interventions, really should see a mental health provider. And this was traditionally also the case for adults. But increasingly, it was a recognition that you don't necessarily have to have a whole, psychology training course or a psychiatry residency to be able to make this diagnosis. And this was recognized in the current WPATH standards of care, where they say that this task of confirming the gender identity could be conducted by another type of health professional, as long as they have appropriate training and is competent. And that means they go on to say later on that this could be the hormone provider. So in my personal practice, I take on this task myself. And part of the reason that I do that is because I feel like I do qualify based on the standards of care, but also because one of the biggest complaints that we hear as healthcare professionals from patients is that we are putting up a lot of barriers for patients to get the care that they need. And so asking my patients to see a mental health provider is one more barrier. There is also another model, which the standards of care allude to or mention, but that has really become very, very popular in certain centers in the US. And that is the so-called informed consent model. An informed consent model is basically acknowledging that we are talking about adults, and adults can make decisions as long as they know all the pros and the cons, so the risks and the benefits. And so the idea here is that you're not necessarily trying to make a diagnosis. You are talking to the patient who's seeking feminizing or masculinizing care, and you are talking about the risks and the benefits of, say, hormones, for example. And if the patient feels after learning about all this that they want to proceed, well, they can consent to that because they are adults. So this is really trying to avoid all gatekeeping and really putting the decision in the patient's hands. Having said all of this, almost all of my patients still see a mental health provider. And that is not so much because I need help establishing whether they are transgender or not, because that's usually pretty straightforward. If the patient comes in and tells you they're transgender, they probably are. But the mental health provider can be really, really helpful in guiding the patient and supporting the patient. And there are many challenges that are associated with this situation of gender incongruence. And so learning about what the options are, thinking about how do you tell your family, how do you tell work, how do you transition at work, for example, from a male, say, gender role to a female gender role or gender expression. They can also be very helpful to help evaluate for and manage other mental health concerns. So unfortunately, in the US, as throughout the world, I think, transgender individuals are exposed to a lot of discrimination, stigma, and marginalization, and minority stress. And so as a result, there are much higher rates of depression, anxiety, PTSD. And so certainly the mental health provider can be very helpful in addressing some of those. I mentioned here psychotherapy if needed. I just want to make the point that the role of the mental health provider is not to try to change the gender of the patient, because you can't. They're really there to be supportive. So with that as background, once you have sort of confirmed the gender identity, you have assessed for and managed coexisting psychiatric conditions, you might consider proceeding to transgender hormone therapy if that is something that's within what the patient wants. And so there's a question there too, who should do that? A hormone prescriber should have adequate training. Now, I'm coming to you as an endocrinologist, so I've spent years studying hormones, but there are only a few thousand endocrinologists in the US. I think the situation is similar in India. And so I don't think it has to be an endocrinologist who prescribes the hormones. In fact, probably most of the hormone care is done in primary care by a physician or a nurse practitioner. And that has the advantage also of allowing one place where all the other healthcare needs can also be met. And this is sort of suggested in the standards of care that this might be the best model, with more complicated cases being referred out to specialty centers. But the truth is that many primary care providers are just feeling that they're not well trained. So as a result, oftentimes it does end up happening that the prescriptions are, or the hormonal management happens in subspecialty clinics. I think it's important, though, to think about what are the goals of transgender hormone therapy. And the goal really is to help the patient with their gender affirmation process. And the way hormones can help with that is by promoting a physical appearance that is more congruent with their gender identity. Now, there are many downstream benefits of hormones, including on mental health outcomes. And we're getting more and more data showing that mental health outcomes are better in patients who receive gender affirming care compared to those who do not, including hormones. So we're really trying to change the physical appearance. If we're trying to feminize the body, we tend to use estrogen. So I know there are many medical students in the audience, and so you might recognize the hypothalamic, pituitary, testicular axis here with negative feedback. For those who are not medical, you don't need to worry too much about this, but we give estrogen to try to feminize. And although estrogen actually would, in theory, shut down the hormones in this axis due to negative feedback, in practice, in people with testicles, this is not it does not readily shut down. So you tend to have residual production of testosterone that can really make the feminizing process more difficult. So as a result, we have to give a second medication. And there are a few options here that I've listed. One option is to give this medication leuprolide, or there are other ones also that are in the class of GnRH analogs. They basically act by shutting down the axis from the top. Or you can block testosterone at the level of the receptor. And so we have a couple of options here. Spironolactone is the one that we use in the US. And cyproterone acetate is one that is used in other parts of the world, including Europe and Canada, I believe. So this way, you've sort of attacked both the adding the estrogen and blocking testosterone. So let's just talk a little bit more about estrogen, just a very brief overview. So the estrogen that we give for gender affirmation is typically not birth control. So in birth control, you have a type of estrogen called ethinyl estradiol. And this has been shown to have higher rates of venous thromboembolism, of blood clots, compared to the other form of estrogen that we use instead, which is estradiol. And estradiol is available, it has been approved for the use of treating menopausal women who have menopausal symptoms. So we have a few different forms of giving it. Most commonly is either tablets or a patch, a skin patch, transdermal. And there is an injectable form also that is sometimes used. And we basically titrate the dose to get estrogen levels in the blood up to the levels that we might see in an adult female, in an adult cisgender female. I will say, so this is an example of a range here that you might target. I will say that there is some discussion about what range you might want to aim for various reasons. But certainly you don't want the levels to be sky high, because you want to avoid side effects, which we'll talk about in a minute. Depending on patient preference, we might start slow and work our way up slowly, or we might try to hit this level very quickly and start at somewhat of a higher dose. We don't know that there's a benefit in terms of feminizing with one approach versus the other. So it tends to be sort of patient preference. Patches have these transdermal patches. They have the advantage of having a lower risk of blood clots, but they're really not meant to bring the hormone levels this high. And so sometimes you have to use several patches, and it can be difficult to achieve high enough blood levels. And then I'll briefly say, we mentioned how there are a few options to block testosterone. And in theory, the most effective medication is Leuprolide or Lupron. But this is a very expensive medication. And so it is really difficult for us to get access to for our patients. And it can be a hassle. It's an injection either every month or every 3 months. So it can be a hassle for the patients if they have to come into from a distance, which is why we end up using more the tablets. Spironolactone, you're probably familiar with, you may have come across in kind of using heart failure and liver disease, but it has as kind of a second effect that it blocks testosterone at the level of the receptor. Cyproterone acetate is, as I mentioned, not available in the US, but it's widely used elsewhere, and it does have a few other side effects. It can raise the prolactin level, which is another hormone in the blood. And it can also maybe lead to these benign tumors in the skull called meningiomas. There are many other things that people might use. I just want to mention finasteride, which is actually a prostate medication originally. Now, our patients might have prostate problems and take finasteride, but for feminizing, it really doesn't add much if you have been able to bring the testosterone levels down. So we don't really use that very much. Once the patient has had an orchiectomy, if that's part of what they're planning to do, then you can stop these medications and just keep the estrogen going. Now, many of you may be familiar with progesterone as another female hormone, and that is true, but we really don't know that it has a good role in this setting. I will say we also don't have evidence showing that it has no role, and many patients feel like progesterone might help with breast growth. So as a result, we have many patients coming to request it, and so occasionally I will use it on a case-by-case basis, but this is not in the guidelines. The guidelines say that there's not enough evidence. There are side effects. The main one is blood clots, weight gain, and other cardiovascular risk factors. So we do talk a lot about smoking cessation in this setting. And I will just say that in general side effects, there are situations where maybe you might have some concerns about estrogen, such as if someone has a history of migraines or something like that. And in that case, we might still consider estrogen in this situation simply because we don't have a lot of other options. And the benefits are so great that we might be willing to take a little bit of extra risk if the patient is aware and informed. A lot of my time spent in the first visit is setting expectations because the changes are very, very slow. You can see all the changes that you might expect here to the physical appearance, but many of them take 2 or 3 years to get established. What they often see early on is a reduction in erections and in libido. And in some cases, that is a side effect. In some cases, that is a beneficial effect. It depends on what the patient's goals are. The second medication that we use, or the second process that we use a lot, is masculinizing treatments. And for this purpose, we tend to use testosterone, obviously, as the hormone that masculinizes the body. And it turns out testosterone itself alone very quickly will shut down the hypothalamic pituitary ovarian system or axis. So as a result, we don't usually need to add a second medication. Testosterone alone is usually enough to shut down the ovaries and reduce estrogen, and then it will provide masculinizing effects. So we can give it as an injection, and we've really moved now to subcutaneous injections rather than intramuscular, or there are transdermal gels that you can use. We, just as we talked about in feminizing therapy, we bring the levels up to a target range, and the target range is the normal cisgender male range. And again, whether you go there quickly or slowly is kind of up to the patient and their preference. We don't know that medically that it makes a difference. In terms of side effects, there are side effects of any medication, testosterone also, and we see this in cisgender males also who receive testosterone. You might see a high red blood cell count in the blood, you might see weight gain, acne is very common, and hair loss, and other side effects. What is a bit more specific, though, to the transgender population is that they are at risk of getting pregnant, at least if they have their ovaries and uterus intact. So with the risk of pregnancy, this is a problem because testosterone is teratogenic. It can cause birth defects. In addition, testosterone is actually in the body converted to estrogen. So if there is a history of cancers that are sensitive to estrogen, breast cancer, uterine cancer, then we might be more careful with using testosterone. Again, the effects take a long time to get established. So stopping periods happens quickly. Most of the other aspects take several years to get established. Sort of similar to puberty, you know, a boy that goes through the standard puberty, it's not just 6 months after puberty that they are fully masculinized. You know, it's well into the 20s before that happens. Finally, you know, we monitor our patients closely. So we start them on hormones, and then we see them back. I usually see my patients back every 3 months for the first year. And I ask them about what sort of changes they've seen in their appearance. And we keep an eye out for the blood levels of the sex hormones. And we also look for side effects, both on primarily by blood tests, by looking for high hematocrit or looking for changes in other hormones. Because there is weight gain, I also like to keep an eye on lipid panels and hemoglobin A1C to look for kind of other cardiovascular risk factors that I should be addressing. So with that, that was a whirlwind overview of the hormone care for transgender patients. There's obviously a lot more you can learn about this, and so I put in a few references here for your you know, for those that want to learn more. And I'll just end by saying that someone who's well trained can provide most aspects of the mental health and medical care of transgender people. And for hormonal therapy, we give one hormone, and sometimes we have to block the other hormone. And so with that, I thank you.